Greetings, everybody, and welcome to the ASAP webinar. We're delighted you are here, and we have a few slides for you to start with. So my name is Catherine Brokenshire-Scott, and I'm the ASAP Project Director, and today's topic is gender equality and GBV prevention and response services in USAID's PEPFAR programs. We are delighted to have 2 USAID staff members and a local partner from South Africa. So welcome Amelia Peltz and Emily Reitenauer, and Suzanne Hoffman from NACOSA. We're really happy that you've taken the time to share all of this information with our participants. So I'd like to make a couple of announcements. The most important one is we kindly ask you to use the Q&A tab to ask all the questions that you have. We ask that you use this tab so that we can retain the questions. If you use the chat function, the questions can disappear. And we do make a big effort to write answers to the questions so that you can get documentations on the Q&A after the webinar. About 30 minutes before the end of the webinar, we will launch a poll. It's a very short questionnaire. We appreciate your responses. It helps us plan for future webinars. And now, as always, all of our webinars, recordings, and questions and answers are included in the IntraHealth ASAP website, which you can see here. And then finally, today's presentation will be sent later today to all participants. Finally, my last slide before I turn it over to our USAID colleagues is we have our upcoming webinar on March 25th on optimizing human resources for health staffing. We will be sending out a quarterly invitation with all of the webinars for the next 3 months. So thank you. I hope you enjoy the webinar, and over to you, Emily. I'll stop sharing now.
Hi, everyone. Thanks so much for being here. I'm really happy to be here with you all today. I'm going to pass it over to my colleague, Amelia Peltz, who will get us started. Amelia, over to you.
Thanks very much, Emily. Good morning and good afternoon to you all. My name is Amelia Peltz, and I am the team lead and senior gender advisor of the Gender and Sexual Diversity Branch in the Office of HIV/AIDS at USAID. I am joined by my colleague, Emily Reitenauer, who is a gender advisor on our team. And we are pleased to join you today to discuss gender equality and gender-based violence prevention and response services in USAID's PEPFAR programs. We are also very pleased to welcome Cezanne Hoffman, the National Program Manager for NACOSA, one of our partner organizations in South Africa. Cezanne will be speaking later in the webinar about NACOSA's experiences in providing gender-based violence services and how they've worked to overcome the many challenges posed by COVID-19. Next slide, please. This is the agenda for our session today. We will start by covering some basic terminology that we use in USAID's PEPFAR programs, just to ensure we are all on the same page, and then discuss the global prevalence of GBV, as well as the relationship between GBV and HIV outcomes. The next section of the presentation will focus on USAID and US government policies on gender and gender-based violence, and then specifically USAID's gender and GBV technical priorities for PEPFAR programs. We'll then cover some basic information on the PEPFAR Monitoring, Evaluation, and Reporting Indicator, or the MER indicator, pardon me, that we use to track progress in one aspect of our GBV programming. We will then discuss some emerging issues with COVID-19 and GBV, and there's where we will feature our partner in South Africa, NACOSA. We will then conclude the presentation by sharing additional technical resources and covering any additional questions that you may have. Next slide, please. So to start, we will cover some basic terminology. Next slide. Great. So the first definition is sex. Sex is the classification of people as male or female. At birth, infants are assigned a sex based on a combination of bodily characteristics, including chromosomes, hormones, internal reproductive organs, and genitalia. Typically, when a mother delivers a baby, the baby is assigned a sex based solely on the baby's visible genitalia. However, biological sex is much more complicated than just someone's genitalia. Biological sex includes a person's chromosomal, hormonal, and anatomical characteristics. The next definition is gender. So the definition that we use is that gender is the socially defined set of roles, rights, responsibilities, entitlements, and obligations of females and males in societies. The social definitions of what it means to be female or male vary among cultures and change over time. In other words, this is how society sets boundaries of what is considered acceptable or proper for men and women, boys and girls. Gender identity is a person's deeply felt internal and individual experience of gender, which may or may not correspond with the sex assigned at birth. Gender identity is how a person understands their own gender. It is deeply felt and can remain private. The formation of gender identity is influenced by hormones, the environment, biological sex, culture, class, and other personal circumstances. Being born biologically one way, but then identifying another way, for example, someone who is biologically female, but who identifies as a man, may cause distress in places with rigid gender norms or hostility towards gender nonconformity. And finally, sexual orientation is an enduring pattern of romantic or sexual attraction, or a combination of these, to another person. These inherent attractions are generally subsumed under heterosexuality, homosexuality, bisexuality, or asexuality. Sexual orientation is about emotional, romantic, and sexual attraction. Everyone has a sexual orientation, and sexual orientation exists along a continuum. Gender identity and sexual orientation are important to understand because individuals can often be discriminated against if they are perceived to go against society's norms. Next slide, please. So this character, who we call the gender person, demonstrates those 4 key dimensions of a human being in relation to gender and sexuality. So you'll see biological sex, gender expression, gender identity, and sexual orientation. And it can be a helpful way of remembering those definitions that we previously covered. Next slide, please. So the next definition that we want to cover is gender-based violence. Gender-based violence, or GBV for short, is an umbrella term for any harmful threat or act directed at an individual or a group based on an actual or perceived biological sex, gender identity or expression, sexual orientation, and/or a lack of adherence to varying social norms around masculinity and femininity. So that's a really long sentence. And what does it actually mean in the real world? It means that GBV is rooted in the structural gender inequalities, patriarchy, and power imbalances that we see in our societies every single day. GBV is characterized by the use or the threat of physical, psychological, sexual, economic, legal, political, social, and other forms of control or abuse. GBV impacts individuals across the life course and has indirect costs to families, communities, economies, and global public health and development. Next slide, please. This slide provides 2 helpful definitions of violence against children. WHO's definition focuses on all forms of violence against people under the age of 18. And the USG definition specifies different types of violence. Both definitions are important, and they're very useful to frame conversations around violence against children, or VAC for short. Next slide, please. So this slide illustrates different forms of violence against children. The definitions of these types of violence are in the slides, and they will be available to you as a resource at the end of this webinar. But just to note that when violence directed at a child or adolescent because of their biological sex or gender identity, any of these types of violence are also considered gender-based violence. Next slide. So these structural inequalities and power imbalances due to age and gender perpetuate gender-based violence against children. Forms of violence against children can include child abuse, including sexual abuse, female infanticide, neglect, child marriage, female genital cutting or mutilation, and trafficking. Next slide, please. So now that we have covered the basic terminology, we'll review some data around the global prevalence of gender-based violence. Next slide. Okay, so let's start off with a pop quiz. So what is the global prevalence of violence against women? Is it A, 1 in 10 women will experience physical and/or sexual violence from a partner or sexual violence from a non-partner? Is it B, 1 in 5 women? Or C, 1 in 3 women? So feel free to type your answers into the chat box. I see people saying 1 in 3, or answer is C, 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 C. Yeah, exactly. Next slide, please. Correct. So the answer, congratulations to those of you who answered C. The answer is 1 in 3 women will experience physical and/or sexual violence from a partner or sexual violence from a non-partner in their lifetime. Next slide, please. So this is a graphic from the World Health Organization that shows the lifetime prevalence of violence against women across different regions globally. It's important to note that regional estimates can mask important national and subnational estimates, which are often higher than the regional estimate in total. In addition, certain population subgroups may be at higher risk, such as pregnant women, women living with HIV, women with disabilities, Indigenous women, and women who engage in sex work. Next slide, please. This is a graphic, again, from the WHO that illustrates the different types of violence that women may experience in their lifetime. In USAID's PEPFAR programs, we are primarily focused on intimate partner violence, non-partner sexual violence, and violence against children because of the proximate link to HIV. Next slide, please. Okay, so if someone were to say to you, only women experience gender-based violence, would you say yes or no? Feel free to, again, put your answers into the chat box. We're seeing a lot of no's. Okay, great. Could we go to the next slide, please? Right, so unfortunately, the answer is no. Gender-based violence is also experienced by children and adolescents, both boys and girls, as well as by key populations, which include men who have sex with men, sex workers, people who inject drugs, transgender individuals, and people in closed settings, such as prisons. Next slide, please. Great. So focusing again on violence against children for a moment, this is a graphic that illustrates the prevalence of violence against both girls and boys. The violence against children surveys, also known as the VAX surveys, are an important source of data on violence against children, especially because they cover both boys and girls. Next slide, please. So the data from the VAX surveys has also shown us that even when young survivors disclose their experience, when they tell someone about the violence they're experiencing, they rarely seek or receive services, including post-rape care. And in this graphic, you can see the very wide gap between, in this case, females who told someone about their experience of violence and those who actually got help. Next slide, please. This graphic from the previously USAID-funded Linkages project highlights both the type and frequency of violence against key populations globally. As the map notes, violence against key populations is prevalent, frequent, and often severe. Next slide, please. Gender-based violence is experienced throughout a person's life. This is a graphic illustrating gender-based violence across the life course, which has these indirect and direct costs to families and communities. Next slide, please. So another yes or no question for you. While gender-based violence is a human rights violation, it does not impact HIV outcomes. So again, in the chat box, feel free to answer yes or no, depending on what you think about this. Okay, seeing a lot of no's. Can we go to the next slide, please? And we'll see the answer. Right, so the answer is no, and our next set of slides will explain why. Next slide, please. So now we're going to take a bit of a closer look at the relationship between GBV and HIV health outcomes. Next slide, please. So another interactive moment here for us. How do you think gender-based violence impacts HIV outcomes in a person? Feel free to type some of your ideas in the chat box. How do you think GBV impacts HIV? Poor adherence, increased rates of infection, low adherence, preventing access to treatment, increases the risk of HIV, physical compromising, impacts on PrEP uptake, late to HIV testing, poor disclosure, unsuppressed viral rate. Yeah, no use of protection. Female sex workers don't get care due to stigma. Yeah, that's an important one. Low negotiating skills, adherence to ARVs. Yeah, these are all great, great examples. Can we go to the next slide? Okay. So we'll focus on the relationship now. Thank you all so much for your engagement and for your answers in the chat box. This is great. We're seeing a lot of really important points here, all of which are true. So we want to focus in on the relationship between gender inequality, gender-based violence, and HIV. So as it's been well documented, gender inequality and gender-based violence are some of the most critical barriers to reaching HIV epidemic control. Globally, 35% of women experience intimate partner violence or non-partner sexual violence in their lifetime. And women who experience intimate partner violence are 1.5 times more likely to acquire HIV. The experience of gender-based violence, particularly intimate partner violence, is associated with lower use of antiretroviral treatment, half the odds of self-reported ART adherence, and significantly worsened viral suppression among women. Intimate partner violence has also been found to lower adherence to pre-exposure prophylaxis or PrEP. So in short, violence poses a substantial barrier to the effectiveness of HIV services and can undermine the uptake of and adherence to proven biomedical prevention and treatment options. Next slide, please. So GBV poses a significant barrier to our efforts to achieve epidemic control. Throughout this presentation, we have seen how GBV is both a cause and a consequence of HIV. They really are mutually reinforcing epidemics. As such, preventing and responding to GBV is essential to meeting PEPFAR's 95-95-95 goals. So this is a graphic that our team developed, which illustrates how GBV impacts each phase of the HIV clinical cascade and really serves to underscore the importance of addressing both the HIV and GBV epidemics concurrently. Next slide, please. So this is a graphic that was produced by the STRIVE Consortium, and it illustrates the pathways between intimate partner violence and HIV risk. Now, contrary to popular belief, sexual violence appears not to be the main factor explaining the association between violence and HIV at a population level, which is important to underscore, at a population level. Although individual women can and do become infected with HIV through rape or forced sex, a number of other indirect pathways appear to be more significant. One of these pathways is sexual abuse in childhood, which sets up a cascade of developmental and psychological consequences that can lead to a range of risk behaviors. And these may include earlier sexual debut, more sexual partners, and substance abuse. And these increase a woman's risk of both acquiring HIV and of becoming re-victimized by violence in adulthood. A second important factor is the HIV status of a woman's sexual partners. It has become clear through the evidence that men and boys who abuse women and girls are themselves more likely to be HIV positive, which in turn increases the risk of HIV acquisition among their partners. Men who are violent are also more likely to engage in a range of risk behaviors, including having outside sexual partners, abusing alcohol and other substances, engaging in anal sex, and visiting sex workers. Finally, the emerging evidence also suggests that violence and trauma have a biological effect on immune and hormonal functions believed to be important in helping HIV acquisition and disease progression. Thus, women living in abusive relationships or violent settings may be biologically more at risk of acquiring HIV and possibly of HIV progressing more rapidly. Next slide, please. This is a graphic from the World Health Organization illustrating some of the adverse health outcomes among women experiencing gender-based violence, including the increased likelihood of experiencing depression, increased risk for HIV, which we've been talking about, as well as the risk of serious injury and death. Next slide, please. So I think that we have come to our first pause in the presentation. We'll pause here for some clarifying questions before we continue on.
Thank you for that, Amelia. We have two questions at the moment. The first question for you, Amelia, is it considered gender-based violence if two men fight over a land dispute?
If two men fight over a land dispute. Typically, I do not think that we would classify that as gender-based violence, because gender-based violence is usually, when we look at the definition, it includes issues around inequitable norms and power structures, usually between males and females, or if it's between two men, it could potentially be that one man perceives that the other to be transgressing social norms about what it means to be a man. So in this particular example, if a fight is over land, that's not necessarily a fight over one person saying, hey, you're not a man because you behave in this certain particular way. So in this case, my response to that would be, no, we wouldn't count that as GBV, but Emily, I don't know what your thoughts on that are.
I would agree. This is not a fight or dispute or violence based on one's gender identity, gender expression, sexual orientation, but over a dispute of land. And because of that, I would not classify it as gender-based violence. Thank you, Amelia. Another question for you, Amelia. Is it considered gender-based violence if a mother beats a girl child?
In this case, yes, we would consider that gender-based violence, because we would be, and it's specifically a form of violence against children. In this case, we are seeing a pretty significant power disparity, a power gap between the mother and that girl child. Also, because in many societies, social norms say that that beating children by parents is socially acceptable because children need to be disciplined, is considered a form of GBV, yes.
Thanks, Amelia. We're getting a lot of questions about, is this considered GBV? Is this considered GBV? One of those questions, does gender-based violence include violence in same-sex relationships?
That's a great question. And yes, it absolutely does. Just because there could be two males or two females in a relationship, absolutely. The data around violence in same-sex relationships, it depends on the country. Some countries have really good data around this, and some don't necessarily collect data on this, given the legal status of same-sex relationships in countries. But we do know that, unfortunately, it is quite prevalent. So yes.
Thanks, Amelia. One more question about, is this GBV? Is it considered gender-based violence when women are given a higher chance to participate in something? Yes.
So I think it would be helpful to have a little bit more clarity on this question. When women are given a higher chance to participate in something, I'm not entirely clear on what this might mean. I think when, there's a lot of great questions here about what defines violence. And I think, you'll have a copy of all these slides later, but violence is different forms of physical, physical abuse, emotional abuse, sexual abuse, these kinds of things. I think when you're looking at it in relation to this question here, when women are given a chance to participate in something, this could be a case whereby historically perhaps women were not included. So if you're thinking about, let's say, education, and where historically girls have not had as many opportunities to go to school as boys. And so perhaps there is a policy in place to ensure that we're focusing specifically on girls going to school. That wouldn't be a case of violence. That would be a policy directive in order to address inequalities and promote greater gender equality in education.
Thanks, Amelia. Two more questions so far. One is, can you please expand more on how prenatal sex selection manifests and the connection to GBV?
Mm-hmm. So as we noted earlier in the presentation, femicide or sex selection, which is a procedure to abort a fetus when it is discovered to be female, is a form of violence because the reason for that aborted fetus is because it's female, and families, or there might be pressure there to not have more girl children because girl children are deemed less worthy than boys. And so unfortunately, yes, femicide is practiced in some societies and cultures, and it very much is a form of abuse, to the point where we have seen in some cultures these major sex ratio gaps between males and females.
Thanks, Amelia. Somebody has asked for more clarification on what the term genitalia means and what the term asexuality means.
Sure. So genitalia are the male and female sex organs. So for men, it would be, the penis, the testes. For women, it would be, the vagina, the uterus. That's the genitalia. Asexuality is when a person feels no physical, sexual, emotional, or romantic attraction to anyone. So there is just a complete absence of that kind of attraction.
Thank you, Amelia. There are several more questions. I think we should move along, but the last one I'll note for now is, what is the difference between GBV and abuse?
Sure. So gender-based violence, it really is an umbrella term, and an umbrella term means it encompasses a lot of different forms and types of abuse. And so in this case, abuse would be a subset of gender-based violence. It could be physical abuse, emotional abuse, sexual abuse, and it is one type of GBV.
Thank you, Amelia. Please keep your questions coming. You can add your questions into the Q&A box, and we will endeavor to get to all of them. We will have space throughout the presentation for questions, and then at the end of the presentation, we will have more space to answer any questions you have and to follow up on ones that we may have missed. So if you do have questions, please continue to enter them into the Q&A box. Thank you. Moving on, thank you so much, Amelia, for that overview of HIV, GBV, and gender inequality. We are now going to review our U.S. government and USAID policies and strategies on promoting gender equality and addressing gender-based violence. Using a two-pronged approach, USAID's PEPFAR-funded gender and GBV activities advanced several key strategy and policy documents, including the PEPFAR Gender Strategy, the USAID Gender Equality and Women's Empowerment Policy, and the US government strategy to prevent and respond to gender-based violence globally. The two-pronged approach USAID uses to advance these key strategy and policy documents includes integrating gender and GBV considerations into facility and community-based HIV prevention, testing, and care and treatment programming, and focusing on standalone priority areas, such as preventing and responding to gender-based violence, including violence against children, and activities to address gender and social norms that impact HIV outcomes. These three strategy and policy documents on the screen provide the foundation for USAID's two-pronged approach, guiding our work in addressing gender inequality and gender-based violence, which, as Amelia discussed, are two significant barriers to HIV epidemic control. We will now discuss how USAID addresses gender inequality and GBV within our HIV programs. Gender inequality and gender-based violence impede the effectiveness and success of USAID PEPFAR programs, impacting HIV prevention services and each phase of the HIV clinical cascade. As such, preventing and responding to gender inequality and gender-based violence are essential to meeting 95, 95, 95 goals. In the same way we perceive the HIV clinical cascade, we also perceive GBV prevention, case identification, and response as a cascade, focused on improving HIV prevention, testing, and treatment outcomes. There are 4 key gender and GBV technical priorities for USAID PEPFAR programs. The first priority is addressing intimate partner violence in PrEP, index testing, and care and treatment services through GBV case identification and the provision of first-line support. The second priority is delivering post-violence clinical care services through HIV care and treatment sites. The third priority is improving linkages between community-based HIV and GBV prevention interventions and clinical post-violence care services. And the fourth key technical priority that we will discuss today is improving monitoring of GBV case identification, prevention, and response activities. We will now review these technical priorities in a bit more depth. All USAID PEPFAR sites delivering PrEP, HIV index testing, and HIV care and treatment services must conduct GBV case identification. Within PrEP service delivery, GBV case identification must take place during PrEP initiation counseling. Within index testing services, clients who elect to participate in partner notification services must be asked about experience of violence for every named partner. And during care and treatment services, providers must ask clients who they suspect are experiencing violence based on signs and symptoms about their experience or fear of violence. While our approaches are grounded in WHO guidance, one important distinction to note is that for GBV case identification, USAID recommends a hybrid approach of both clinical inquiry and routine inquiry for intimate partner violence in our HIV programs.
Emily, sorry to interrupt you. Some people are having a hard time hearing you. Is it possible to move a bit closer to your microphone?
Yes, is this better?
A little bit. Can you speak again?
Is this better?
It's a little better, yes. But it seemed we could hear you, but it was very faint. So I don't know if it's possible to get closer to your microphone. But I think
sure. Is this better?
Yes, it sounds better. Thank you.
Okay, thank you. Sorry about that, everyone. Thank you, Amelia. So, as I was saying, in USAID's programs, we use both clinical inquiry and routine inquiry for identification of intimate partner violence. As a reminder, or for those of you who are unaware, clinical inquiry is when providers are trained on identifying signs and symptoms of violence and ask about experience of violence when a client presents with those signs or symptoms. Routine inquiry is when providers ask everyone who presents for a specific health service, such as PrEP or index testing and partner notification about experience of violence. So not asking every client about violence at every service delivery point, but only at specific service delivery points, such as PrEP and index testing. This hybrid approach, using both clinical inquiry and routine inquiry, is informed by the WHO clinical and policy guidance, which states that routine inquiry may be considered in the context of HIV testing and counseling, as well as when assessing conditions that may be caused or complicated by intimate partner violence, such as HIV. It's important to note that WHO has stated that it recommends that only clinical inquiry be used. As just described, USAID recommends this hybrid approach, using both clinical inquiry and routine inquiry, because we acknowledge that not every USAID PEPFAR site that is required to ask about violence is able to use a clinical inquiry approach. It's important to note that for sites to ask about experience of violence, for sites to conduct routine inquiry for intimate partner violence, they must meet 6 minimum requirements. So listed on this slide are the 6 minimum requirements that USAID programs must meet to ask about experience of violence. These minimum requirements are essential to ensuring clients' safety and well-being, as well as the provision of quality care to survivors of violence. These 6 minimum requirements are as follows. First, providers must offer first-line support using the LIVES approach developed by WHO. Providers should never ask about experience of violence unless they are able to provide first-line support. Second, a protocol or standard operating procedure for asking about the experience or fear of violence from an intimate partner must be available at every site. Third, sites must use a set of standard questions to ask about violence where providers can document responses. This is particularly important to help limit any provider bias that may influence how questions are asked. Fourth, providers must be trained on how to identify signs and symptoms and/or ask about experience of violence. Fifth, providers should only ask about intimate partner violence or sexual violence in a private setting where confidentiality can be ensured. And finally, sixth, there should be a documented process that all providers are familiar with that offers referrals or linkages to other supportive clinical and non-clinical services for survivors of violence. I'd like to take a moment to emphasize the first minimum requirement listed here. Providers must be trained on and offer first-line support using the LIVES approach. The provision of first-line support is a critical component of GBV case identification and response. First-line support can often be the most important care a survivor receives and significantly impact their willingness and ability to access GBV response services, which can impact their HIV outcomes. I hope many of you know this if you participated in any of the LIVES trainings, but first-line support is the immediate care given to a survivor of gender-based violence upon first contact with the health or criminal justice system. WHO developed the mnemonic LIVES to describe the approach used to deliver first-line support. In USAID's PEPFAR programs, we often refer to first-line support as LIVES. Within LIVES, the L stands for listen. This means listen closely to the survivor with empathy and do not judge them. The I stands for inquire. This means assessing and responding to the survivor's emotional, physical, social, and practical needs and concerns. The V stands for validate. This means that when someone discloses that they have experienced violence, the provider shows that they believe and understand the survivor. The E stands for enhanced safety. It is important to discuss how to protect the survivor from further harm and to help the survivor plan for their safety. And lastly, the S stands for support, which involves helping the survivor connect to services and other forms of social support through referrals. Again, first line support is the immediate care given to a survivor when they disclose experience of violence. All providers who ask about experience of violence must be trained on the provision of first line support. Moving on, the second gender and GBV technical priority for USAID's PEPFAR programs is integrating post-violence clinical care services into HIV care and treatment sites. USAID has primarily two models of service delivery for post-violence clinical care services: standalone sites, which are often referred to as GBV one-stop centers, and integrated sites, where post-violence clinical care services are delivered at HIV care and treatment sites. Our goal is to ensure that all USAID HIV care and treatment sites that provide the full minimum package of post-violence clinical care services are tasked with delivering clinical GBV response services. We'll discuss the minimum package of post-violence clinical care in a moment. The third priority is improving linkages between community-based HIV and GBV prevention interventions and clinical post-violence care services. In non-clinical community-based interventions, individuals should only be asked about violence as a part of standard OVC case management or during assessment for eligibility for DREAMS programming. Individuals found to have experienced or be experiencing violence should immediately be provided with first-line support and actively referred to post-violence clinical care services. Additionally, individuals who present at facilities for post-violence clinical care services should be referred to community-based HIV and GBV prevention programs as appropriate, such as DREAMS, OVC, and community-based key populations interventions, as well as community-based violence response services. And the fourth technical priority for USAID's gender and GBV programs that we'll review today is improving monitoring of GBV case identification, prevention, and response activities. This includes ensuring correct reporting on the MER-GBV indicator, as well as using custom gender and GBV indicators and disaggregates to measure GBV case identification, prevention, and response activities, as well as gender norms change activities. I have a question for you all. If you could just please enter this in the chat. What is the name of the PEPFAR MER indicator that captures the number of people who receive post-violence clinical care services? What is that indicator? Please put it in the chat if you think you know. Okay. Okay, I'm getting a lot of Gen GBV. Good. It's Gen GBV. This is the one and only MER indicator that captures PEPFAR GBV response programming. We do, as USAID, have custom indicators and disaggregates that we strongly encourage implementing partners report on, but the only official MER indicator for GBV is Gen GBV. We are now going to review this very, very important indicator. Gen GBV measures program performance for PEPFAR-supported post-violence clinical care services. This indicator captures the number of individuals who have received post-violence clinical care services based on the minimum package. Can anyone just write in the chat, what is one service that you know of that is included in the minimum package of post-violence clinical care services? Just type in the chat, what's one service you know of that's included? I see HTS, I see PEP, treatment of injuries, STI testing, counseling, testing, PEP, emergency contraception, STI screening. Great, great. Yes, wonderful. Yes. So the minimum package of post-violence clinical care services as defined by WHO and PEPFAR and as articulated in the GBV indicator reference sheet in the PEPFAR MER indicator reference guide includes treatment of injuries, rapid HIV testing, post-exposure prophylaxis or PEP, emergency contraception, STI testing or screening and treatment, counseling, meaning the provision of first-line support using the LIVES approach, which we just reviewed, and referrals to other local GBV response services as necessary, such as longer-term psychosocial support, shelter, police, legal, child protection, economic empowerment, etc. As mentioned here on the right, post-exposure prophylaxis, or PEP, should be offered if a client presents for services within 72 hours of experiencing sexual violence. I have another question for you all. How many days is 72 hours? Please type your response in the chat box. How many days is 72 hours? 3, good, yes. So within 3 days, within 72 hours of experiencing sexual violence, a client is eligible for post-exposure prophylaxis. Additionally, as mentioned on this slide, emergency contraception should be offered if a client presents for services within 120 hours of experiencing sexual violence. How many days is 120 hours? How many days is 120 hours? 5. 5, yes. 120 hours is 5 days. So within 120 hours, within 5 days of experiencing sexual violence, an individual is eligible for emergency contraception. All of these services in the minimum package, which are separated on this slide into services for physical/emotional violence on the left and services for sexual violence on the right, additional services for sexual violence on the right. All of these services must be available and offered at a site for that site to report on GBV. Therefore, if there are sites that do not or cannot offer all of these services, those sites should not have GBV targets, nor should they report on GBV. So for example, if a site can provide all of the services on this screen, except for emergency contraception, and they refer clients for emergency contraception elsewhere, that site should not report on GBV, but instead use a custom indicator to capture their GBV response work. Okay? And if you have any questions about that, please type it in the Q&A. So all of these services must be available at a site for that site to report on GBV. With that being said, a client does not need to receive all of these services to be counted under GBV. These services just must be offered to the client as appropriate. So for example, if a client presents for post-violence clinical care services 10 days after experiencing sexual violence, that client will not be eligible for PEP, nor will that client be eligible for emergency contraception. The client can still be offered other services in the minimum package and be counted under GBV. If that client only accepts some services in the minimum package, they can still be counted under GBV. And again, if you have questions about this, please type in the Q&A. I will just repeat here. I do see a question about sites not offering emergency contraception. So if you have a site, if there is a site that does not offer, but instead refers for any of the services in the minimum package, so for any of the services on this screen, that site cannot report under GBV, but should instead report under a custom indicator to capture their GBV response work. Okay. So we can discuss this more. We can count clients on GBV. Yes, so you can count clients under Gen GBV if they have not received every service in the minimum package. All of these services must be available at the site and must be offered to the client as appropriate. But the client does not need to receive every single service in order to be counted under Gen GBV. Okay. Okay, and again, we can discuss this in more depth. And if you do have specific questions about that, I encourage you to write them in the Q&A. Gen GBV was previously an annual indicator that was only reported through datum in Q4. Starting this fiscal year, so in fiscal year 2021, Gen GBV has become a semi-annual indicator, and it will now be reported through datum twice a year during Q2 and Q4. Additionally, USAID implementing partners ideally report their quarterly Gen GBV data to USAID country teams for submission to the Office of HIV/AIDS in USAID Washington through the Office of HIV/AIDS Custom Indicator reporting process. The reason USAID Washington's Office of HIV/AIDS wants to see this data quarterly is to assist country teams and implementing partners in identifying successes, but also technical assistance needs in a timely manner. So formally, through datum, Gen GBV data should be reported in Q2 and Q4. And ideally, your quarterly Gen GBV results will be submitted to your country team. There are several ways in which Gen GBV results are disaggregated. When reporting on Gen GBV, sites should report the sex of the clients, reporting both females and males served, the age of the clients using finer age bands, the type of violence for which services were provided, either sexual violence or physical/emotional violence, and completion of a course of post-exposure prophylaxis, or PEP. For type of violence, please note that the MER guidance prioritizes reporting sexual violence over physical or emotional violence. So we know that individuals may be experiencing different types of violence, but to avoid double counting, if a client reports experiencing both sexual violence and physical or emotional violence, the client should only be counted under the sexual violence disaggregate when reporting on Gen GBV. And again, this is to avoid double counting. For the PEP disaggregate, a client should only be counted under the PEP disaggregate if the client completed a full course of PEP, which is typically 28 days. Okay. The PEP disaggregate does not therefore capture initiation on PEP. It only captures completion. If a client is not eligible for PEP, if a client chooses not to take PEP, or a client just does not complete the course of PEP because of default or loss to follow-up, the client can still be counted under Gen GBV, but should not be counted under the PEP disaggregate. Understanding what is included under Gen GBV is as important as understanding what is not included under Gen GBV. So I really want to stress this point. Gen GBV is a clinical indicator. It captures the provision of clinical GBV response services. It does not capture community-based GBV prevention activities, nor does it capture non-clinical GBV response activities such as case management, shelter services, longer-term psychosocial support, education, couples counseling, etc. Gen GBV also does not capture gender norms change activities. Okay. Although these services and activities are not captured under Gen GBV, they are critical to GBV prevention and response and supporting survivors of violence to have improved HIV outcomes. This work is incredibly important. We therefore encourage the use of custom indicators to capture this work. And the results for these custom indicators can be reported into datum through the GenGBV indicator narrative. Okay, so while these activities cannot be captured under GenGBV, they can be captured under custom indicators that can be reported through the indicator narrative for GenGBV and datum. Okay. I know there are lots of questions. I'm going to go right now through the Q&A. If you have entered questions in the chat, I encourage you to enter them as well in the Q&A just to make sure that we are able to capture them and provide responses now as well as in writing. So I can start going through this. If a client reports after 3 days, what services will the client get? I didn't quite get the 10-day explanation. So let's go back to the minimum package here. If a client reports after 3 days, they are eligible for all of the services here on the left, as well as emergency contraception if that individual is biologically female. Okay? The client then has the right to determine what services they would like to accept and what services they do not want to accept. So if a client presents after 3 days of after experiencing sexual violence, and that client is offered all of the services, let me get my pointer, and the client is offered all of the services on the left and emergency contraception, and the client decides to turn down one of these services, that client can still be reported under GenGBV. Okay. What is the rationale of screening DREAMS on enrollment only? Given their age vulnerability, it may be difficult for adolescent girls to disclose violence to somebody they are not familiar with during enrollment. Yes, so when we talk about GBV case identification, we're talking about asking about experience of violence. We only recommend explicitly, specifically asking about experience of violence during DREAMS enrollment because we're trying to determine risk and vulnerability. We do know, however, and what often happens within DREAMS programming is that adolescent girls and young women who participate in DREAMS often disclose experience of violence to their mentors in their safe spaces, to facilitators of their GBV and HIV prevention interventions. It's for that reason that we insist that those individuals, that those who are facilitating HIV and GBV prevention interventions, including community health workers or mentors, be trained on the provision of first-line support so they are able to respond appropriately to those adolescent girls and young women who disclose experience of violence, and they're able to refer. We do not encourage that mentors and community health workers actively identify individuals who are experiencing violence outside of enrollment. But we do necessitate that those who are implementing and facilitating HIV and GBV prevention interventions be trained on how to respond when violence is disclosed. Please go over PEP completion again. What do you mean when you say custom indicators? Okay, so GenGBV has a post-exposure prophylaxis, a PEP disaggregate. This disaggregate captures the number of people who receive post-violence clinical care services, including PEP, and who complete PEP. So it doesn't count the people who initiate on PEP. It counts the people who have completed a full course of post-exposure prophylaxis. When a client who has received post-violence clinical care services completes the full course of PEP, they can be reported on under that disaggregate. When we talk about custom indicators, this is separate. So again, GBV captures the number of individuals who receive clinical post-violence care services. We know, however, based on the minimum package, we know that there are many sites and many implementing partners that do really incredible, important GBV prevention and response work that is not captured under GBV, that cannot be captured under GBV, including sites that offer many but not all of the services in the minimum package. We want to be able to count that work. We want to be able to measure reach for that work because it's incredibly important. And so because of that, we encourage the use of custom indicators. Custom indicators are indicators that are not PEPFAR indicators. They're indicators developed by the implementing partner in collaboration with their AOR or COR and their country, USAID country team technical leads. And we encourage that these GBV prevention and response activities be captured under these custom indicators and that the results be reported through datum through the GBV indicator narrative so that PEPFAR, as well as USAID Washington, is able to see the results for all of that important work. Okay. Let me see. So if a site, great question. If a site has a temporary stock out, it cannot report under GBV. That is absolutely correct. And it's one of the reasons why we really encourage implementing partners and sites to develop plans for how they will ensure that they're able to avoid stockouts. So for instance, some of the practices that we have seen that some sites have adopted agreements with fellow facilities, where if they have a stock out of, say, post-exposure prophylaxis, drugs for post-exposure prophylaxis, they are able to acquire a limited amount of supplies from a neighboring facility, essentially borrow that so that they're able to offer those drugs on site, and then essentially reimburse that neighboring facility when their stock when their drugs are restocked. I want to be really clear about why we necessitate that the full minimum package be available at a site in order for that site to report on GBV. And that is because many of the individuals who are presenting for services, presenting for post-violence clinical care services, have experienced tremendous trauma. It is, for many individuals, very difficult to disclose experience of violence and to seek services. We really want to limit the number of places that a client must go in order to receive these really critical services. We also want to limit the number of individuals who the client will need to speak to and tell their story to, because it is traumatic every single time the client must do that. This is why we insist that all of these services be available at a site in order for that site to report on GBV. Okay, so if a site doctor gives a prescription to a survivor to buy emergency contraception drug and the pharmacy is out of sight. Yes, so great question. If a clinician at the site writes a prescription for any of the services in the minimum package, and the client needs to go to a pharmacy outside of the site to get that drug or that service, that site should not report on Gen GBV. All of these services must be offered at site. 120 hours for emergency contraception. Does this mean they are now effective within 5 days instead of 3? So WHO says that emergency contraception, that individuals who experience sexual violence are eligible for emergency contraception within 5 days of exposure, within 5 days of experience of violence, within 120 hours. For post-exposure prophylaxis, it's 72 hours. Please ensure that you're also adhering to national government guidelines. So some countries may have different timeframes, but according to WHO, one who experiences sexual violence is eligible for emergency contraception within 120 hours and is eligible for post-exposure prophylaxis within 72 hours. Okay. Going through questions.
Emily, we might want to take maybe just one more for now and then move on to the next section for Suzanne's presentation.
Great. Okay. Last question. For treatment partners that work in hospitals, survivors may be referred to family planning unit within the hospital. Is this okay? That is okay. We do recommend that if you're referred to the family planning unit within the hospital, that there be somebody who can escort the survivor to the family planning unit and can explain what service is needed and why. And this again is to limit the number of times that a survivor needs to tell their story. But thank you everyone for the questions. Again, we will come back to these questions at the end. And if we do not answer your question today, please know that if you have written your question in the Q&A box, we are noting these and we will provide written responses and send those to all webinar participants after today's session. So thank you for your questions. Moving on, I'm now going to hand it over to Amelia, who will discuss GBV and COVID-19. Thank you.
Thanks so much, Emily. And thanks everyone again for your questions. As Emily noted, we are keeping track of these and we'll get responses even if they're not all answered. So we wanted to spend a bit of time briefly talking about COVID-19 and gender-based violence. Next slide, please. So unfortunately, as the data has been showing us, HIV and gender-based violence are syndemics with a baseline prevalence of GBV of anywhere between 30 to 50% in the countries where PEPFAR works. So understanding that we're already working with a population that's experiencing high levels of violence means that in times of stress like COVID-19, these rates are going to further increase. Some of our partners have reported a dramatic rise in the number and severity of GBV cases being reported, while others have been also showing a decline in the number of cases reported. But this has been attributed to survivors not being able to get help due to some of the strict lockdown measures that have been put in place to keep the spread of the coronavirus in check. Next slide. So what this has all meant with the increased risk and rising number of cases of violence is that we need to continually adapt our programs using a range of solutions that meet the needs of all survivors. And this includes using a combination of mobile and online technologies to provide counseling and safety planning, also employing low-tech options to reach individuals who do not have access to or control over their own mobile phone or internet connection, and also finding safe and innovative ways to reach the most vulnerable and isolated in the community. Next slide, please. We also need solutions to help health and social service providers adapt service delivery methods, particularly counseling and safety planning, and to support, to cope with and manage increased stress and trauma, including vicarious trauma. Next slide, please. So we are very fortunate to have one of our South African partners, NACOSA, with us today to talk about some of the work they are doing to provide GBV services. So I'm very pleased to introduce Cezanne Hoffman. Cezanne is currently working for NACOSA as the National Program Manager on a 5-year USAID award that seeks to prevent HIV amongst South Africans who have been sexually assaulted and provide services to children, adolescents, and caregivers vulnerable to HIV. She also has previous experience working on large Global Fund programs focused on community response and systems strengthening. So Cezanne, we will turn the presentation over to you. Thank you and welcome.
Thank you so much, Amelia. Good day, colleagues. As Amelia introduced me, I'm Cezanne Hoffman, and I'm working at NACOSA. NACOSA is a network of over 1,800 civil society organizations that are working together to turn the tide on HIV, AIDS, and TB in Southern Africa. We do this through promoting dialogue, building capacity with accredited training, mentoring, and technical assistance, and also channeling resources to support service delivery to children and youth, key population, women and girls. A core focus of our program and well integrated in all of our programs is how we prevent and respond to GBV. Can you move to the next slide, please? So I wanted to start my presentation today with a quote from the UN Secretary General that said that peace is not just the absence of war. Many women under lockdown for COVID-19 face violence where they should be safest, in their own homes. Next slide, please. So the stark reality of this quotation is reflected for us in the most recent South African crime statistics for the October to December 2020 period that was recently released by our National Police Minister. During October to December, 12,218 people were raped. Of those rapes, 4,900 or 40% took place in the home of the victim or the perpetrator. We now know that up to 50% of all South African women will be raped in their lifetime, and 46% of sexual offences in South Africa are indeed against children. As Amelia has spoken earlier, that the research has shown that violence, and especially sexual violence, have a profound impact on social and economic development, mental health, substance abuse, and significantly increases the risk both through direct and indirect pathways for HIV for survivors. So in South Africa, GBV is indeed our second pandemic. Next slide. Like most countries around the world, South Africa had to be very agile and responsive in the manner it has needed to adapt to challenges brought about in the health and the GBV sector due to COVID-19. South Africa experienced our first wave of infections from March 2020, with infection rates peaking in July 2020 and showing a gradual decrease till December, when new infections surged. This second wave of COVID-19 that we are facing is characterized by a much more transmissible variant that is causing many more excess deaths. Although services, next slide please. Although services to GBV survivors have continuously been seen as an essential service under COVID-19 lockdown restrictions, it has been severely affected by COVID-19. I wanted to just explain a little bit around what are the services that we are offering, and then also how that has been affected. So NACOSA is focused on providing a comprehensive package of services to GBV survivors that is inclusive of acute services, short-term and long-term services. So acute services are rendered when a survivor is just reporting for the first time the incident. This is inclusive of trauma containment and psychological first aid, supporting access to the GBV minimum package of clinical care, as Amelia and Emily has highlighted. So access towards HDS, PEP, STI screening, emergency contraception, treatment of injuries, and then as per the need of the survivor, additional linkage to care and treatment support services such as ART, STI treatment, or SRH services could also be facilitated. Survivors also have access to comfort packs and emergency transport. So following this period of the acute reporting phase, short-term support services are rendered that is focused on looking at GBV case management, supporting the completion of PEP, looking at counseling, very important safety planning, and as we saw with the 46% of survivors being children, looking at child protection interventions or referrals. Survivors are also referred to shelters or places of safety if this is needed, and informed about their rights and supported with coping strategies. From a longer term perspective, we're looking at how do we aid the survivors in their journey to recovery. Programs like trauma-focused cognitive behavior therapy is offered to children and their caregivers, survivor support groups, and survivors are linked to economic support programs to strengthen their socioeconomic circumstances. Next slide. So for all of these services, COVID has had such a significant impact on the uptake of these services. Community members were less likely to access health facility or designated facilities in fear of contracting COVID. During the peak of our infection periods, many health, social welfare, justice agencies and resources suffered temporary closures, and this affected the accessibility of these services. Community mobilization activities such as dialogues, awareness programs at schools were also affected during lockdown periods. Next slide. So our NGO partners put in significant effort to reach GBV survivors. This included engagement with media, looking at TV, radio stations, social media platforms, to inform the population and audiences of the services that's available, to promote their crisis lines, and to encourage uptake of services. Key stakeholders were also approached, such as police stations and ward councillors within communities, to make sure that they have information about services that are available and that they can support and promote access to post-violence care from a very grassroots level. Casualty wards and hospitals were visited to ensure that there was clinical inquiry for GBV, and information was provided on what the referral processes for GBV would look like. Our community care workers, linkage officers, first responders, and social workers also acted as local referral agents in their communities, and through this process, streamlining timeliest access to services. Partners also increased their collaboration with the justice system to identify, support, and refer GBV survivors, specifically those that have been victims of IPV and sought protection orders, for these survivors to also access a comprehensive package of health and other social services. Next slide. We prepared a snapshot slide just to show you what the effect has been of COVID-19 on the reported cases. It has to be noted that this is limited to the facilities supported by our award. So we've seen a significant decrease in the reported numbers during the April-June period. This is when South Africa experienced their hard lockdown period and also had a subsequent alcohol ban. Reported cases during this period was mostly 65% sexual violence in nature. We see during the July-September period, when economic activity resumed, schools reopened, and community activities resumed, a sudden and a very dramatic spike in increases in reported cases. Towards the end of November and beginning of December, where we've experienced our surge in new infections and our second wave, we see a dramatic decline again in the reported numbers, despite the festive season historically being a period of increased reporting. This could be an indication of the avoidance of health facilities and the fear of COVID contraction during this period. Next slide. We've also observed some key trends during this time, that 44% of reported cases were children, very much aligned to what our crime statistics are showing us and the NSP for GBV. 89% are female and 11% are male. Of the male survivors, 30% were under the age of 18. 71% of the survivors knew their perpetrator and 49% reported intimate partner violence. 2% of the cases reported tested HIV positive for the first time. NACOSA looked at a few programmatic strategies to look at how do we really, next slide please. NACOSA looked at leveraging some program strategies and solutions in response to these trends that we identified. So through the implementation of a decentralized model, strengthening accessibility of GBV services at primary and community health facilities, also looking at through this process, providing capacity building to healthcare workers focused on the lives approach to make sure that we are responding adequately to violence and specifically also for IPV survivors. There's also been an increased focus on improving access to child protection and family strengthening activities through partnerships with our OVC and DREAMS programs. At a community level, we are implementing evidence-based group interventions such as Empower and Stepping Stones to look at how do we address gender norms, promote psychosocial well-being, and develop knowledge and skills to prevent and respond to GBV. NCOSA notes and emphasizes the significant psychosocial support that is required by GBV survivors, and through ongoing training and development of social workers on trauma-informed methodologies, aims to address the profound impact that GBV and violence has on women and children. We also note the need for support services for male children that are survivors of sexual violence and how this provides a unique opportunity to break the cycle of violence. And this is a programmatic area that would be further explored for us. We want to thank you all for the opportunity for us to share our work today, to share our services, and to be part of this global peer learning platform aimed at supporting our most vulnerable women and children. Thanks.
Thank you so much, Suzanne, for that excellent presentation, and would encourage you all to put your questions into the Q&A function. We're really fortunate to have Suzanne with us today and her expertise, and so this is a great opportunity to ask her questions and tap into her wisdom on the provision of services, especially during this very difficult COVID-19 period. So we have come to the end of our formal presentations, but we're now going to focus the remainder of our time on the Q&A portion of the session. And I think a poll has come up. I'm wondering, Fikra, if you wanted to talk about this at all?
Sure. If you guys could please answer the questions in the poll, they'll be used for feedback for this webinar. So we would appreciate it. Thank you so much.
Great. So we still have some questions here in the chat box that we want to go back to. And I think there's a couple of questions here, Suzanne. I would love to get your perspective on it from your experience in providing services and your work through NCOSA. We've got one question here I'm looking at. What should you do if a parent does not want to involve the police when her adolescent has been sexually abused, and in parentheses, teenage pregnancy, claiming the father won't be able to take care of the baby if arrested? Would you like to comment on that or offer some thoughts on that?
So I think that we need to consider the fact that South Africa specifically has mandatory reporting requirements for sexual abuse of children. So if the provider becomes aware of this, there is a mandatory reporting requirement and the involvement of the police and social development and a whole host of support services to support this family. So I think that we need to look at it both from the perspective of saying that you've got a mandatory reporting requirement, as well as the perspective of working with this family in terms of putting the necessary support structures in place for them to be able to adequately respond to this violence that the young teenager has experienced.
Thank you so much. We have another question for some background. So it says, in Zambia, we have noticed that Zambia Police Service GBV numbers are high compared to our one-stop centers. It may also be because we capture numbers using different parameters, yes. We are looking at trying to work with the police to ensure their numbers and ours are not too different. What is the South African experience? Excuse me, Suzanne, would you like to answer that?
Yes, so I think that we are experiencing, or we're seeing similar in South Africa, that there's a higher number of cases reported at the police than what ultimately receive services at GBV, what we call Tutuzela care centers or designated sexual violence centers. And I think part of the work that we're trying to do at community level is closing that gap. You know, seeing that how do we make sure that there's adequate transport available for survivors? How do we make sure that they're not having to sit prolonged periods of time at the police station, having to wait for a police vehicle to become available to take them to facilities? And then also within our decentralized model, looking at making services more accessible at a local level for beneficiaries or for survivors. One of the challenges that we also face in South Africa is that many of these one-stop centers are 200 or 300 kilometers away, you know, from where survivors are within communities. So it's really about, for us, how do we also look at making these services more accessible, and how do we make sure that transport is not a barrier for survivors in terms of being able to link to services. We've also been looking at, you know, case managers very closely linked with different entry points in terms of police stations, health facilities, so that there is somebody that the person at the police station can call to say, you need to hold the space. You need to make sure that this survivor is adequately linked to care.
Thank you, Suzanne. And another question for you. So in South Africa, how do you adhere to COVID-19 SOPs as you engage the community?
So I think that we have very detailed COVID-19 infection prevention control measures in place. We are looking at very much aligning ourselves to government restrictions and levels in terms of venue size, ventilation, having outside, you know, events, limiting the number of people, social distancing, masks, sanitizer, and just really being very mindful of how we, you know, interact with our communities and how we interact with each other. So it has been a learning curve for all of us. It has been a new normal for all of us, putting all of these measures in place, making sure that there's COVID compliancy officers, lack of a better word, at each community event or at each group session or training that we have that is enforcing these COVID prevention measures for us.
Thank you, Suzanne. I see another question. We are requesting to have soft copies of the policy documents together with the slides. Thank you for that question. I'd like to note that at the end of this presentation, we actually have a list of technical resources where we have the links to those documents on the slide. And again, you all will be given the slides so you can access those policy documents. Another question, if a site can provide post-violence care services, but needs to integrate free services with fee services, with paid services, can that be done? I want to really stress the importance that all services in the minimum package, and I'm just going to put that up here again for your reference. All of these services should be offered at a site, and they should all be free of charge. It's really important that we do not charge clients for any of the services on this slide, any of the services in the minimum package. Okay, if a client couldn't get the full minimum package just because he or she couldn't get to the facility on time, do we still include clients under the indicator? Yes, absolutely, please. So if you have a client who presents for services, and they told you that they experienced sexual violence 3 months ago, that client is not eligible for PEP or emergency contraception, but they are eligible for all other services in the minimum package, and those services should be offered to the client. If the client accepts even just one of those services, the client can be counted under Gen GBV. Okay. In Kenya, increasing cases of incest are a challenge for health workers to manage. Are there SOPs in place for this area? Suzanne, I would love it if you could speak to this. Is incest, increasing cases of incest, an issue in South Africa, and how has NACOSA responded to this?
Okay, so I have to note that we haven't collected data specifically on incest. We have collected data to say that at least 71% of cases were a known perpetrator. And in many instances, we're seeing this to be a father, an uncle, a stepfather, a grandfather. So there's definitely a very high rate of known perpetrator violence against children. This comes back to this trauma-focused cognitive behavior therapy, long-term support to survivors of sexual violence, looking at providing a comprehensive package of services that includes long-term care, that includes health care, and in many instances might even require referral to specialist services like psychologists or psychiatrists, due to the nature and many times the longevity of the violence or of the abuse. So it is something that we are dealing on a case-by-case basis, but I would say that it requires significant investment in that survivor, and it requires significant support from a multidisciplinary perspective.
Thank you, Suzanne. I have another question for you. How does South Africa respond to cases of unlawful sexual relationships between teenage girls and older men? This is a challenge that the person who asked the question says that they face, is that police or the courts do not address these cases to completion, and in most cases, perpetrators are not prosecuted. So how does South Africa respond to cases of unlawful sexual relationship between teenage girls and older men?
Okay, so I think that for South Africa, that forms part of, statutory rape for us. I know that transactional sex in communities are still very high. The culture of a blessee and a blesser relationship. And it is something through the extensive programming, through dreams, through looking at creating economic opportunities for girls, through looking at providing comprehensive sexuality education and support, as well as through our statutory services and sexual violence services are addressed. So it is a challenge, I think, for us in South Africa, like in other countries as well. But we do have some very specific guidelines that from a criminal justice perspective guide that for us. The reality is that until girls are in a space where they are also economically capacitated, strengthened, this would continue to be a challenge. So I think as a GBV program, our integration with very important activities such as economic strengthening, such as social asset building, really is critical in managing this process as well.
Thank you, Suzanne. So here's a question. It says, does Gen GBV record just sexual violence and other forms of violence are captured under a custom indicator? No. So Gen GBV captures both sexual violence and physical and or emotional violence. Okay. So these three forms of gender-based violence, sexual violence, physical violence, and emotional violence, and services for these 3 forms of violence per the minimum package are captured under the Gen GBV indicator. If you have a client who presents for services and they present for physical violence and sexual violence, you will only report under sexual violence to avoid double counting. If they report emotional violence and physical violence and sexual violence, you will only report under sexual violence to avoid double counting. Okay? If they present and they've experienced physical violence but not sexual violence, you will report under physical violence. The reason we prioritize sexual violence is because we're trying to also capture, or actually because of the direct relationship between HIV transmission and sexual violence. And we're also able to see how many individuals could be eligible for post-exposure prophylaxis. Just because an individual has experienced sexual violence does not mean that they will be eligible for PEP. They may present after 72 hours. They may decide that they do not want to take PEP. They may know that they're HIV positive and are not eligible for PEP. However, the number of individuals who report receiving services for sexual violence serves in many ways as a denominator for the PEP disaggregate. And that was another question that was asked in the chat. Okay. What we ask that you capture under custom indicators and disaggregates are these non-clinical GBV response activities, as well as GBV prevention activities, as well as gender norms change activities. Okay. What service can you offer a client who is physically abused by a boyfriend but is not willing to report to the police? If you have a client who has experienced physical violence, as listed here on this slide, you can offer that client any of the services here on the left of the screen. Because they haven't experienced sexual violence, they've experienced physical violence. So you can offer any of the services on the left of the screen, okay? We do not capture under the PEPFAR MER indicator the number of individuals who report experience of violence to the police. We only capture the number of individuals who receive these health services as per the minimum package. Okay. Let's see. Sure. So, Suzanne, there is a question about what happens if a parent does not want to report a case of their child being abused. What would happen then if you identify that a child has been abused, but the parent does not want to report? Can you talk a little bit about that, Suzanne?
Back to what we have noted previously, that under our Children's Act in South Africa, we do have mandatory reporting requirements for teachers, social workers, any community member that knows that a child has suffered violence or sexual violence or abuse, that there is a requirement for that to be reported both to the police as well as social development for the appropriate action to be taken. I think it's working closely with that parent to understand the fact that what the impact of the abuse is on the child, what the impact of non-reporting for that would be, and also what the legal requirements of you as the service provider or the implementing partner is if you are aware of abuse happening against a child. So it is a difficult process. But the reality is that you do have a mandatory reporting requirement, and it is best to work with the family to look at them going to a space of being comfortable in reporting this and understanding that they could also be criminally charged if they do not report, violence against children. And we do see cases like that in South Africa where parents have known that their children were being sexually abused and have not reported it, and has subsequently then also faced either jail time or fines in relation to that. So it does happen. And I think it's just being very open and very clear with your beneficiaries that you are serving about what the actual requirements are in relation to the Children's Act.
Thank you, Suzanne. Do we have statistical data speaking to exposure of violence by the boy child? So we do. Many countries have completed the violence against children surveys. And most of these violence against children surveys capture data on experience of and exposure to violence by children, both girls and boys. All of the VAX reports that have been published to date can be found on the website Together for Girls, which we can link in the chat box for all of you. But we do have data on that. What can you do when there's no health facility with the complete minimum package in order to provide services for a survivor? So if there's a facility that does not provide the full minimum package, they can still provide services for survivors, as many services in the minimum package that they have, and they can refer the survivor to other facilities for other services. That site can just not have Gen GBV targets because they do not provide all of the services in the minimum package. We also strongly encourage that if that site is referring the survivor to another site for additional services, that be an active referral or even an escorted referral, so that again, the survivor does not need to tell their story once again to the other site. So again, this minimum package is what ideally sites that provide post-violence clinical care services should have in place in order to provide quality care to survivors of violence. This minimum package is what is also needed to be in place in order for a site to report on Gen GBV. If a site does not have all of the services in this minimum package, that does not mean that they cannot provide services to survivors and refer survivors for additional services. That just means that they cannot report under Gen GBV. And instead, we encourage those sites to work with their implementing partners and USAID country teams to develop custom indicators for which they can report. Okay. Suzanne, there's a question if you could speak a little bit more to the implementation of evidence-based activities in your program. I know you mentioned stepping stones and empower. If you could maybe talk a little bit more about how those are used in your program, and if you have any other evidence-based interventions that you implement.
Sure. So Empower is a sexual violence prevention.
Suzanne, I'm sorry, we can't hear you. If you could just speak a little louder.
Okay, sorry. So we implement two evidence-based curricula, Empower and Stepping Stones. So Empower is a sexual violence prevention program developed by No Means No worldwide, and it is really focused on teaching girls skills around self-esteem, that they have worth and value to say no. It teaches them boundary setting, but then it also teaches them physical self-defense skills as a last resort to attackers. Currently, because of COVID-19, there is an adjusted curricula called I'm Safer, which is an evidence-informed curriculum. that still teaches all of the soft skills in terms of violence prevention and self-esteem and boundary setting and being able to recognize, when you are in danger. But it just demonstrates the self-defense part and does not practice it due to COVID guidelines and due to social distancing guidelines. Then we also implement Stepping Stones, which was a program developed by the Medical Research Council. And this is really focused on teaching both young men and boys and young women and girls around gender norms. It looks at good psychosocial well-being and health, and explores relationships between men and women and gender myths and stereotypes, and opens up those conversations between young girls and men to ultimately move to a space of changing gender norms, at a community level. So I'm more than willing to pass on more information. If you want to put your email address in the chat box, and we can discuss a little bit more about these evidence-based interventions.
Thank you, Suzanne. Suzanne, would you also like to respond to this question? It would be good to hear from the South Africa perspective. Do you support or implement interventions for providers to address vicarious trauma?
So, as part of our trauma-focused cognitive behavior therapy that we do with our social workers, there's a strong element of supportive supervision, of debriefing, of vicarious trauma, of being able to support our healthcare workers, our first responders, our linkage officers, our first line of response against GBV on how are they dealing, with disclosures daily. How are they dealing with communities that are very reliant on them, for being referral agents? So it is an integral part of our program, and it's built in through monthly supervision sessions, through peer learning opportunities, through debriefing sessions. We also, even in our evidence-based interventions like Empower or I'm Safer and Stepping Stones, are building in an additional layer of saying that you would need to look at monthly debriefing sessions with these facilitators because they will be faced daily with disclosures from young women, and they will be faced with having to, through that process, also deal with own traumas that they may have experienced, growing up or being young women in South Africa.
Thank you, Suzanne. Okay. What other indicators are reported for GBV and gender norms? So the official MER indicator that is reported into DATM for GBV is Gen GBV. We do have a series of custom indicators that we encourage, and disaggregates that we encourage implementing partners to report on, one of which is Gen norm, which many of you may remember. It's an older or previous MER indicator that captures the number of individuals who have participated in gender norms change activities in alignment with three main requirements. We often refer individuals to two compendiums developed by Measure Evaluation, specifically that are focused on gender-based violence and also focused on gender equality within HIV programs. Those are two resources that we are happy to include in our written responses when we type up responses and send the responses to the questions out to you all, just so that you are able to see those yourselves. And it is from those compendiums that many country teams have identified custom indicators for GBV and gender equality. I really encourage you to reach out to your country team if you're thinking about potential custom indicators, because this is something that they likely have also thought about and may have some ideas for how you can capture your gender and GBV activities that are not reported under Gen GBV. I have another question for you, Suzanne. It says, young people seem not to adhere to the COVID-19 prevention measures. What youth-friendly ideas do you use in South Africa, or have you considered in South Africa for young people to easily take COVID-19 prevention measures into consideration?
I think that's a difficult question to answer. I think it is quite layered, you know, in terms of the different responses. So from a communications perspective, it's about looking at tailoring messages that is specific, you know, to your youth target audience. It's about having youth-friendly IEC materials that speak to you know, COVID-19, and also having child-friendly materials that speak to that, that really show children and youth what the risks are, how they can prevent COVID. From a perspective of implementing programs, we have found that sometimes the physical demarcations or restrictions help. So where we are implementing group sessions, having hula hoops or cones physically showing, you know, a 2-meter distance, making sure that hand washing, mask wearing is part of the normalized approach of implementing group and community sessions. So many times it's not just about saying it, but it's about showing it as well, and making sure that that is the consistent message that youth are seeing at all of your events, at all of your meetings, your community engagement, your group sessions, if that is happening, and just reinforcing that through targeted messaging and IEC materials. And if you are doing, you know, WhatsApp follow-ups or broadcast messaging, just keeping on to make sure that you are re-emphasizing that same message again and again.
Thank you, Suzanne. I'm seeing a lot of questions about lives. So just to reiterate, anyone who asks about experience of violence, whether within PrEP, HIV index testing, care and treatment, DREAMS, OVC, and NKP programming, needs to be trained on how to respond when violence is disclosed. They need to be trained on first line support using the lives approach. So if your providers or your counselors or your healthcare workers are asking about experience of violence, they must be trained. We do have a standard set of, we do have examples of a standard set of questions that can be asked for experience of violence, and that's something that we can share with you when we provide written responses to these questions. And in the questions that we recommend, we also have some KP friendly questions, KP sensitive questions. So those can be included as well. Amelia, would you like to handle this question or respond to this question? How are IPV related adverse events to index testing managed?
Thanks very much for the question. So PEPFAR, through its interagency network of USAID, CDC, and DoD, has compiled a series of tools and resources used to both identify and respond to adverse events within index testing. All of these materials are available on the PEPFAR Solutions site, and we will make that the link to those materials available in the written answers to all the questions and answers we've had during the webinar. So we'll make sure that's available, but it's a fairly detailed set of materials that have been developed. But to say that there are some very important requirements that we need to ensure are in place to ensure that all of the minimum standards around the WHO 5 Cs for index testing are in place. When it comes to issues of intimate partner violence, earlier in the presentation, Emily showed a slide on the minimum elements that need to be in place in order to ask someone about violence and provide an appropriate response. That is a key part of ensuring that we are responding to adverse events in the context of index testing. But again, we will send out that link again to the PEPFAR Solutions website where all of these materials can be accessed. Thanks.
Thank you, Amelia. Suzanne, perhaps you can respond to this question. Community leaders are afraid to report violence and abuse because police and caseworkers inform the suspect of who reported him or her to them. So how can we solve such an issue in the community whereby we are able to protect the reporter of abuse? Is this an issue in South Africa? And if so, is there anything, any best practices or any solutions that are being considered or implemented that you can share, Suzanne?
So I think for us, one of the key important elements have been that our sub-awardees or our implementing partners are at community level. So there's very good engagement with police services, with community leaders, with ward councillors, with traditional leaders, and they are sensitized towards GBV, and they're sensitized towards the needs of GBV survivors, as well as the reporting and the referral pathways. And that's really been the way in which we have, managed this. I'm not saying that in all communities, you will have communities where that is a challenge. You would have communities that people feel that they cannot report or they are scared of reporting. But it's about that close working relationship on the ground between your GBV providers, as well as all of the other role players within the system, whether that's criminal justice, police, traditional leaders, street committees, to really for everybody to be on the same page in terms of how do we address GBV and how do we protect and look after our survivors and our women and children.
Thank you so much, Suzanne. We are now at time, but I just want to thank all of the participants for your questions and your engagement and for your participation today. Many, many thanks to Suzanne for coming and sharing the experiences of NACOSA in South Africa. We greatly value learning from your experience, and thank you so much for sharing about the fantastic work that you and NACOSA are doing. Thank you. Many thanks to Amelia Peltz as well for her technical leadership and engagement in today's presentation. We really just thank you all. Fikre, is there anything else that you would like to share before we wrap up?
No, there's nothing else. Thank you all for attending today. We appreciate it.
Thanks, Fikre. And as a reminder, the slides will be shared. We will also be sharing the recording, and we have noted all of the questions that were submitted into the Q&A box, including those that were answered live. We will be providing written responses to these questions. Any resources or materials that we mention, we will be sure to link those in the questions responses, and we will be sending these to everyone. So fear not, if your question was asked in the chat and it was not responded to, we will respond to that in writing. But again, thank you very, very much to all of you for coming today, for your questions and your engagement. We greatly appreciate it, and you will be hearing from us soon with responses to your questions. Thanks, everyone. Have a great day.